because inadequate bowel preparation, which is reported up to 25%, does have some patient implications. It's a cause of longer procedures, incomplete colonoscopy, missed pathology, but it also increases the cost and the complication risk. The BPPS, or the colon preparation, also correlates with the ADR, where we can see that an excellent bowel preparation, so 9 out of 9 BPPS, has an average adenoma detection rate of 43% in a recent study. But when the preparation was adequate but not perfect, so a BPPS of 6 or 6 to 8, then the ADR dropped to 26%. And we also saw a difference in the mean amount of adenomas that were detected in these patients. What are the causes of an inadequate bowel preparation or predictors? Well, I've highlighted some of them that are predictors, such as male gender, inpatient status, some metabolic factors as diabetes, hypertension, cirrhosis, narcotic use, constipation, etc. There's actually one important one that would make your bowel preparation easier or better, and that's IBD. The ESGE guidelines also state how to improve your bowel preparation. One of them is a low-fiber diet on the day preceding the colonoscopy or a couple of days before. The use of enhanced instructions, such as a phone call a couple of days before, doing consultations to explain bowel prep, having brochures, having an application, videos, etc. They also suggest adding oral simethicone to the bowel preparation to increase the adequacy of the bowel preparation. They recommend to use a split dose bowel prep because it is better than a single dose or a single day preparation. And the last dosage should be taken within 5 hours to the colonoscopy and should be finished 2 hours before starting the colonoscopy.
So the first thing I do is pull back a little bit to take the pressure off that loop, because it's a stretch, like giving it the discomfort, allow the narcotic to kick in. I can't pull that out at the moment because it's a fairly wide open loop roll, and I got 1-to-1. I go in, I come in, I go in, I go in, come out, I come out. I can't reduce it at the moment. So what I need to do is advance the scope a little bit further, which is why I think you need to have confidence you're going to resolve the issue. And I'm just trying to reach a point where I can, and we've now got a little bit more tip angulation. And I'm really not pushing the scope in at all. I'm just rotating the scope, and I'm going to rotate the scope clockwise and pull back very slowly. And you can see the end spiral forming an end spiral, and then that should hopefully allow me to reduce.
I would have classified that as partially successful, but what weren't you doing, or what could you do differently to make it successful next
I needed to go in a little bit further, Roland.
Okay.
So as I was talking instead of walking, so here we've got reached a point where if I push in, the loop's only going to get worse, and I'm pulling out and I'm getting some forward movement, and I must utilize this forward movement. So my cap is just pushing up against the folds and stopping the tip from going forward. So I'm going to literally park here and add some torque.
So it's clockwise torque here, isn't it?
It is clockwise torque, and I still haven't quite got beyond this fold. I'm trying my best not to move the scope too much, open it up with the fluid, and then get my cap through that gap. And if I can do that, we will succeed.
So there's something about you need to know when there is a problem and what the problem is and how to correct it. And as John was saying, to overcome the problem, some of these difficult problems, you need exquisite tip control. And to achieve that, you need to know how to hold the scope. You need to be moving the scope incredibly slowly, glacially slowly. You need to be very aware of what your right hand is doing and also aware of what the scope is doing. And often when it's difficult, people get very stressed. They get very focused on the endoscopic image, and they don't realize that there's some stuff happening outside the patient that can be easily corrected to make their life a lot easier. And I just want to illustrate one situation which 93% colonoscopists would mostly not be able to resolve. And this is similar to what John was seeing a minute ago, not quite the same. But what we have here is an end spiral loop with a tight hook in the sigmoid descending junction. And this is the lateral view on the right. And the problem here is we have an end spiral, and pushing the scope causes pain. Now, the solution is to anti-clockwise the torque to align the scope so it's in one plane. Then withdraw slowly, adjust the torque dynamically, and withdraw the scope slowly and deangulate the tip. And John, believe it or not, was doing a lot of those things then, but you may not have noticed it. So what we're talking about here is anti-clockwise torque of the scope, and that brings it all in line. So if you look at the left-hand image at the bottom there, the scope is almost in one plane, and it's clearly in a much better position hook in the right. So then we pull back on the scope. We may need to adjust it clockwise or anti-clockwise because this will rock back and forth if you're not careful. And we pull it back into that position. And John had that view a minute ago. And then you've got a lot of scope a lot of colon on the scope here, which makes it very unstable, which is why John failed the first attempt. You have to be very patient here, straighten the tip up, and then slowly move forward. But this is a really, really tricky thing to do. And if you don't know what to do and you don't have the tip control, you'll just never do it. So, in summary, you need to recognize the problem, know the solution, and you need optimal execution of the solution. So if your solution fails, and I challenged John on this in the case, I was sort of asking him why the solution failed. And he said the solution failed because he wasn't in far enough. But there is a question, did he execute the solution as well as he possibly could have done?